Great. Well, why don't we go ahead and get started? I want to welcome everyone to this week's Friday seminar series session within the College of Public Health. We're doing something a little bit new with this session. As some of you probably know, there has been a great deal of discussion, not only between our college and Fox Chase Cancer Center, but also across the university more generally about identifying ways and strategies that we can come out of our school and departmental silos and have an opportunity to learn from one another, to train our students together, but also to potentially identify targets for research and scholarship. So with that in mind, we decided to start this series, or to have this session be dedicated to cancer. Because the reality is that we have individuals across the university and its entities who work in this space. And so what we've done is we've asked a handful of people representing some of the different schools and colleges to talk a little bit about their work. They're loosely grouped together, having to do with environmental exposures, with smoking and lung cancer. You could imagine we could have made that umbrella very, very large. We could have made that umbrella very, very small. But we thought we could maybe bring some people together in that space just to start the discussion. And so what I'm going to do is I'm going to briefly introduce our panelists, and I'm going to give each of them an opportunity in about 3 to 5 minutes to talk about their work, the things that they're working on right now. I've challenged them today and asked them not to use slides, which we all agree is maybe a little bit of a dirty trick on my part, but hopefully they're all up to the challenge. And then I'm hopeful that we can have a little bit of discussion, and would obviously invite all of you to put questions in the Q&A feature of the chat, to engage with them and use this as an opportunity to learn from one another. So our panel today, in no particular order other than this is how they're on my screen, we're joined by Dr. Inkyu Han, who's an associate professor in the Department of Epidemiology and Biostatistics in the College of Public Health. Dr. Eugene Dunn, who is an assistant professor in the Kornberg School of Dentistry, also a clinical psychologist, so very similar training background, not only to me, but many members of our college community, in particular our Department of Social and Behavioral Sciences. Dr. Khadija Mitchell, who is in the Division of Cancer Control at Fox Chase Cancer Center. And then also Dr. Brad Collins, who is a professor in the Department of Social Behavioral Sciences in the College of Public Health, and does a lot of work in tobacco control. So with that, I'm going to turn things over to them. And Dr. Mitchell, I'm going to give you the honor of going first, since you are our guest from physically farthest away from main campus today. So if you want to tell us a little bit about the work you're doing. I know you're relatively new up at Fox Chase, but if you want to tell us about what you're doing up at Fox Chase to get us started, that'd be wonderful.
All right. Thank you so much, David. So my name is Khadija Mitchell. I am an assistant professor, like David mentioned, in the Cancer Prevention and Control program. And in particular, I, by training, am a human geneticist and also a cancer health disparities researcher. And so my lab in particular, we look at population differences and tumor biology. So we focus on lung tumor biology. And we're looking for better ways to understand the actual science of cancer health disparities and how we could use that for precision prevention and precision medicine. And so in particular, we look at changes in DNA, RNA, and proteins, and how that interacts with environmental exposures as well as behaviors, and how this either can increase the risk of developing lung cancer or dying from lung cancer. And I focus on African American populations. And a lot of my work previously, we saw that there was a particular type of genomic signature that seemed to be overrepresented in that population. And so the next thing that we are doing is thinking about the exposome. And so some of my colleagues on the call are very familiar with this. And so in particular, we think about exposures to two things. One, cigarette smoking. And my interest lies in menthol cigarette smoking, because when we look at African Americans that do smoke, 85% of them smoke menthol cigarettes compared to 30% of other populations. And so actually the lab work that we do, we actually look to see what does that menthol cigarette smoke exposure do to drug response. And so we're working with smoking cessation for menthol cigarette smoke, but also thinking about how we can have more precise treatment strategies in that group. And on the other hand, when we think about environmental exposures, we're really interested in residential radon and how once you've been exposed. So just in case you don't know, radon is the second leading cause of lung cancer, but also the leading cause in never smokers, and it has a synergistic relationship with smoking. And so we're interested in thinking about what are the clinical features of radon exposure.
Well, that was wonderful and a great summary. And I wasn't timing it, but that was nice and concise. So, and I was jotting down a few things I'm definitely going to want to follow up on. So, thank you, Dr. Mitchell, for that really nice overview of your work. Dr. Dunn, you're the next farthest away from Temple's main campus. So let's have you go next.
Sure, great. So my connection to cancer research is through my work in prevention and intervention of risky alcohol use and tobacco cessation. So I'm currently at the Temple Dental School, and I provide instruction on tobacco cessation to dental students through a series of lectures in the behavioral sciences curriculum. We teach how research has shown that the most effective treatment for smoking cessation is the combination of nicotine replacement or medication, as well as behavioral therapy. But, how do we get patients to actually agree to either or both of those interventions? So in the courses that I teach, we rely heavily on motivational interviewing. And so this really includes that communication skill and building rapport with patients, having effective listening skills, using empathy, and really collaborating and partnering with the patient, or community members or whoever you're working with to come up with a treatment plan and strategies and goals that are consistent with the patient's values. People rarely change behavior based on a doctor telling them to do so. If only it was that simple, right? What can we do to elicit the internal motivations from patients? And so, as a psychologist, I teach and preach to the dental students to, figure out what their values are, right? Why does preventing cancer matter to that patient? So fear alone, which many dentists think is enough, isn't enough of a motivator, right? It's actually a weak motivator. It's a temporary motivator. So what else can we do? And so, I've been involved in different aspects of substance abuse research throughout my, 15 or so years in the field. I was trained by the American Lung Association doing freedom from smoking. And also have done different, worked on different funded clinical trials using behavioral psychological approaches, things like acceptance and commitment therapy, taking more mindfulness approaches, as well as more traditional cognitive behavioral approaches. I want to shout out, of course, the PI on those two, which was Sandra Japuncic, who's done a lot of, she's at Fred Hutch, or no, she's at, I'm blanking where she is, sorry. But anyway, she's my colleague. She's gone to Michigan. Sorry, she's at Michigan. So anyway, we used an outreach program where we actually partnered with a community health center, and we did outreach calls to patients with severe mental illness. And we did 8 phone calls over a 3-month period using the 5A approach. So ask, advise, assess, assist, arrange. For those who aren't familiar, we could talk more about that. As well as a motivational interviewing approach. And it was actually successful, right? I mean, we did outreach to patients. Over half reported using medications. And we saw a 68% reduction in cigarettes smoked per day compared to which amounted to 17 cigarettes less per day, compared to only 6 less per day in the control group. And so while we didn't get them to quit, right? They did make quit attempts. 80% reported at least one quit attempt, which is huge. And to see a nearly 70% reduction, I mean, we think about harm reduction, that is moving people in the right direction and ultimately making it easier for them as they continue to make quit attempts to get across that finish line, because we know it takes a lot of attempts. So I'll stop there. Looking forward to submitting grants in the coming year at Temple, specifically using a screening, brief intervention, and referral to treatment, or an SBIRT model. So certainly something I'd love to talk more with my colleagues in public health and medicine about, maybe collaborating on those projects.
Great. Thanks, Dr. Dunn. And I think that's a very elegant pivot to potentially one of those collaborators, Dr. Brad Collins. So Brad, do you want to talk a little bit about your work?
I do, yeah. Thank you for putting this panel together, David. I think this will be productive and interesting. So I'm going to focus on an overview of my line of research that's targeting tobacco-related disparities and improving smoking treatment outcomes in populations that experience greater challenges to quitting smoking. Primarily, that's been among low-income smokers and maternal smokers. And a lot of the challenges that these populations experience relate to access-related challenges or barriers to access, but primarily the ineffectiveness of standard evidence-based treatments in addressing the unique challenges of these populations. So I've engaged in research over the last 20 years, most recently a series of 3 consecutive NCI clinical trials designed specifically to improve outcomes of smoking cessation treatments in these populations. And they were designed in large part to capitalize on evidence that parents are motivated to protect their children from secondhand smoke, and our early hypothesis or assertion that harm reduction strategies such as protecting children or creating a smoke-free home are on a continuum of smoking behavior change efforts that can lead to long-term abstinence. So with those assertions and evidence led to our more recent multi-level strategies that were designed to address a variety of key determinants across levels of influence, from health systems levels to individual focused levels of determinants and family or home level determinants. So examples of each of those, at the clinic level or health systems level, we had intervention components that focused on trying to improve providers' adherence to best practice guidelines of pediatricians, which unlike 5As is called the either 2AR or Ask, Advise, Refer. And we first tried that in pediatric settings, Children's Hospital, St. Christopher's Hospital, Temple Health System, and then translated that in a different trial to WIC community clinics. And I can tell you guys a little bit more about that if questions arise. But so we focused on clinic level intervention to try to increase parents' motivation to initiate smoking treatment and link them proactively to more intensive counseling. And in the counseling side of the multi-level intervention, we had multiple modes of intervention that were designed to build skills training, urge management training, designed to enhance self-efficacy by first focusing on more easily adoptable behavior change, which is protecting children from secondhand smoke as a way to prepare them and build confidence in their ability to quit smoking. And we also designed some integrated M-Health and counseling strategies that were guided by supportive accountability model by Moore and colleagues that came out about 8 years ago at this point, that suggests that linking self-monitoring strategies through M-Health to a counselor dashboard, which is how we operationalized it, could facilitate nudging from the counselor to the participants to adhere to daily self-monitoring, as well as to try to provide individualized feedback and skills training. And then we had home level components at the family level. If I have some time, I can give some of our lessons learned that could guide some discussions in among this group. We found that the health systems intervention was feasible, acceptable, and effective in referring clients. So we had in both of the trials about 3,000 referrals over a 2-year enrollment period. The intervention strategy, the multi-level intervention strategies that we used were more effective than standard care in reducing reported children's exposure and increasing smoke-free home adoption. However, in only one of our 3 clinical trials were we able to show a significant decline in child cotinine. And that has a lot to do with kind of the insidious contamination of tobacco in homes that remains months after someone creates a smoke-free home. So we can talk about that from the environmental side. Our interventions were 2 to 3 times more successful than standard care in promoting long-term 12-month bioverified abstinence. However, the quit rates were still below 20% at 1-year follow-up, so there's still a lot of room for improvement. And then secondary analyses, which I think are also could be interesting for discussion. One, we found in 2 different studies, we found a mediating effect that accounted for the observed intervention effect on long-term bioverified outcome. One was the increase of self-efficacy during the treatment period, and in self-efficacy, or the belief in one's ability to achieve smoking cessation and maintain abstinence across challenging contexts. And we also showed a mediating effect of smoke-free home adoption during treatment in accounting for the long-term, the association between treatment and long-term abstinence rates. The other thing we found was in an analysis of our supportive accountability approach that that participants were more adherent to daily self-monitoring when the day after they got a nudge from the counselor, and that adherence to treatment across modalities was related to greater child cotinine reduction and higher bioverified abstinence likelihood. So our current focus is on trying to design strategies to improve self-efficacy, to improve home-level monitoring of secondhand smoke exposure, to provide better precision in the advice that we give to parents around smoke-free home, given the evidence that if we can increase smoke-free home adoption, that could translate to better abstinence rate outcomes.
Great. Well, thanks, Brad. And I think you're right. I think there's lots of different avenues that we can go down based on what you said. So we'll certainly come back to those in a few minutes. Inky, last but not least, you want to give us a little bit of an overview of your work?
Sure. Yeah. So thank you, everyone. Nice to meet you. And I'm an associate professor in the Department of Epidemiology and Biostatistics at the College of Public Health. And I claim myself as an interdisciplinary exposure scientist. I have expertise in environmental and occupational exposure assessment and risk assessment by characterizing the conventional and the emerging contaminant, and then also biomarkers of these contaminants from the human urine samples, the saliva, or the blood, and so on. And actually, my research is especially focused on how we are accurately identify and quantify the different mixtures of these chemicals in our the real-world situations. Is actually try to understand the impact of exposure to mixture of these chemicals on the human population, especially the vulnerable and susceptible populations. And as a kind of first generation immigrant, my research is actually focused on the immigrant workers' health. So one of these the area is I'm very actually the current the federally funded research is related to Hispanic domestic cleaners' exposure to cleaning and disinfectant agent, and also try to identify whether while they are working and what type of the chemicals they are exposed, including carcinogenic benzene or maybe the ammonium chloride and so on. Those are carcinogenic contaminant, and also other the organic chemicals such as like endocrine disruptors or maybe the reproductive outcomes and so on. So and we are actually measuring that their inhalation exposures utilizing the personal air samplers while they are working. And then also we obtain the urine samples and the exhaled condensate, and also blood samples, and by measuring immunologic biomarkers, and then try to understand whether there's any strong positive correlation or the negative correlation. And then if that's so, what would be the determinant of these associations, such as like maybe the work behaviors, or maybe personal characteristic, lifestyles, or maybe their built environment, such as like a home or maybe surrounding environment and so on. So this project is ongoing, and also another related, the immigrant workers project is about nail salon populations. I have been conducting this study over 5 years with the community partners in New York City. And actually, very similar the way that actually we are measuring many different types of the organic chemicals, including phthalates and also organophosphate ethers, such as like those organic chemicals are characterized while they are working, and also try to understand whether those chemical exposures develop their cancers, or maybe asthma or other cardiovascular disease and so on. So this is kind of more also community, the participatory research that I've been working with. And that's the one part of my the study. And then the second the part of my study is kind of more related to emerging contaminant that is in the general population, and also similar to the workers population as well. I'm very lucky to get funded by these Centers for Disease Control and National Institute of Environmental Health Sciences. So actually, I am conducting airborne characterization studies of microplastics in Philadelphia areas. So those are kind of the, you might wonder, it's like we have heard about microplastic exposures by drinking bottled water, or maybe even the using the food and so on. But surprisingly, the microplastic also exists in the air, and then we may inhale those microplastics, especially urban air. For example, like the major sources of the microplastic in the air in urban areas, such as like Philadelphia, might come from the tire wear, because as we know, the Philadelphia road is very grooving with a lot of the gravels, and then there are also the many stop and go traffic because of the heavy traffic jam. So then when the cars stop and go, and actually they emit a lot of the microplastics, and then probably the rubber styles. And so whether we realize it or not, we may inhale them, but we are not sure whether we are actually inhaling those type of microplastics. So I do not know the answer yet, but it's like at least we have to find out whether there are microplastic in the air, especially near the downtown area, or maybe in the Temple areas. So that's the kind of our first the aim, and also hypothesis, to try to identify whether microplastics coming from maybe mobile sources, or maybe from some other recycling facilities, or maybe some other way. And then the second aim of this kind of study is like, if that's so, if there's some hotspots in Philadelphia, and then if that's so, what area that would be, or neighborhood? In that case, the next step of my study is like kind of try to identify those determinants, and then also try to evaluate the potential health impact from the microplastic exposures, and then hopefully improve the health by reducing those exposures. And then third projects that kind of also doing right now is not related to cancer research, but the also funded by the NIEHS, and also like try to understand whether the people, especially living in low-income areas in Philadelphia, they are very susceptible nighttime heat exposures. I think we already know that, but another step that my projects will try to understand is what are the determinants of those nighttime heat exposures, such like whether their housing condition might be problem, or the neighborhood condition might be problem, or maybe their own personal behavior might be a problem. So we kind of try to understand whether the facilitators or the barriers of the nighttime heat exposures among these population. And then by identifying this facilitator and the barriers, and we kind of try to provide the kind of more tailored intervention programs in these neighborhood specific locations, and then try to help them reduce their nighttime heat exposures. So that's the kind of another study. Mm-hmm. And then lastly, the aim of my theme of my project is related to cancer research is it's like I have been conducting the electronic cigarette exposure to aerosols among adolescents, and then also the adult population by the measuring the e-cigarette aerosols and then characterizing many different types of the chemical constituent, such as like maybe the cadmium or the chromium in the e-cigarette aerosols, and then also evaluate the cancer risk, especially those who are using the vapings and other things. So I will just stop here. Looking forward to discussing.
Great, thank you, Inky. So thank all four of you for your overviews of your work. That was greatly appreciated. And for those of you listening in, feel free to start dropping questions or comments in either the Q&A or chat feature, and I'll handle them from there. But one of the things I was really struck by in listening to all four of you is how each of you, through different disciplines and different modalities, seem to have a particular focus on working with underserved communities and how they are particularly perhaps at greater risk for a variety of different factors in response to these exposures. Interestingly, and this is I think where my question comes from, one of the things that I do with my health psychology students when we talk about smoking and tobacco products is I show them the statistics that say that actually smoking rates over the last several decades have dropped profoundly. But it seems like, given the amount of work and energy and funding that's still in the area, there's still work to be done, and particularly work to be done among underserved populations. Am I reading that right? Would you agree that it's that while rates are down in general, there's still perhaps the most vulnerable of our citizens are the ones who still need a great deal of attention?
I can take the first stab at that. Yeah, it's definitely the case. Despite success in the policy and social marketing campaigns over the last 20 years, dramatic decreases in smoking across the U.S. population, but that's given rise to disparities predominantly in low-income communities and high-risk communities like people with mental health issues and maternal smokers. In low-income communities, there's a much higher density of tobacco retailers. There's also people who live in kind of chronically distressed, socioeconomically distressed areas, experience greater psychosocial challenges that relate to difficulty in quitting smoking. So that just from like a emotion regulation perspective, for example, they rely on nicotine to manage their negative moods and their stress. And their stress is at a higher level than higher income communities. So that makes it more challenging to quit smoking. There's myths around nicotine replacement product use that limits access and limits proper use of nicotine replacement products. So that's just a few things that I'll mention, and I'm sure other people can comment on other factors as well.
Yeah, I could just echo some of that. I think we've seen that trend downward in tobacco use, plateauing somewhere around the 14% range, to be determined on what the pandemic will do to that. But if you look at our actual communities, where we work at Temple University, you see much higher rates than that. In the adult community, we see 28, 30% smoking rates. So yeah, and for many reasons, right? Some of it is the marketing and the targeting of advertisements, and what was mentioned about menthol, right? Things that are more addictive and more risky towards our health. And then, Brad was just mentioning, some of those psychological factors, right? Stress management. What are the lives of the folks who live in our communities that we serve? We think about that high degree of life stress. What are they turning towards to escape from that stress, to have any alleviation? And often we hear about smoking being part of that solution, that stress management picture that they report. Granted, if we think about what we know about, right, it's not a stress reducer. They're having cravings and they're smoking to alleviate that craving, but it's that vicious cycle that they are in. Yeah, so I'll pass it on from there.
Dr. Mitchell, you actually mentioned the menthol, and what is it about the menthol that seems to lead people to use it at higher rates?
Right. Well, David, I want to comment on the first thing that you said that will echo with Bradley and Eugene mentioned. So even though cigarette smoking rates have gone down over the past 3 decades, menthol cigarette smoking has gone up, right? And in fact, it's a third of the market share. And so I think that we need to have a discussion about why is the menthol smoking rate going up? And in fact, this is such a public health issue that is why the FDA has moved 3 times, right, thrice, to ban menthol cigarette smoking. I think the challenge is, one, our education and awareness around menthol smoking. There's a lot of stigma and shame associated with those who smoke, but particularly of this cigarette type. And I think because we have the assumption that smoking has gone down, there is some type of deficiency if you can't quit and you continue to smoke. So I think a part of this is social stigma. And of course, my colleagues on the call know more about that from the psychological aspects of things. But that is one of the things. And biologically, there is a difference in menthol cigarette smoking compared to traditional cigarette smoking. So we have pilot data from our lab that shows that when exposed to the menthol cigarette, cells tend to have more genes involved with resistance, particularly to therapy and treatment going up. And I think we also need to talk about genetic predispositions to tobacco addiction. I think we understand that from other types of agents, but we don't really think about that in this way. And so there are physiological changes when you become addicted to cigarettes. And I think we don't talk to individuals who consume in this way. And I think importantly for the at-risk populations, I studied racial and ethnic minorities, the pharmacogenetics of smoking cessation, right? When we think about metabolizing nicotine, we think about smoking cessation medications, we think about receptors and targets and nicotine treatments. This works in conjunction with behavioral practices. So in addition to thinking about CBT strategies, us thinking about when we do give these agents that help quit, and we know that menthol cigarettes are harder to quit. And it's not about, I love what Bradley mentioned, thinking about motivation to quit. In fact, menthol cigarette smokers in some studies show they have higher motivation to quit than traditional cigarette smoking. And the issue is the actual quit attempt. So I think we need to have these multifactorial interdisciplinary approaches to this and thinking about that.
I have a question for Dr. Mitchell, if that's okay, David.
Sure.
I think another issue with disparities, to your point, David, is the concern around children's exposure. And about twice as many children in low-income communities are exposed to cigarette smoke or tobacco smoke daily in their homes. And the rates can be anywhere from 40 to 60% of children in some low-income communities are exposed every day. And the question for Dr. Mitchell, there is the evidence that suggests that children who grow up in homes where smoking is permitted are more likely to quit. And certainly there's genetic components to that, and then learning and behavioral components to that, growing up and observing adults smoking. But I think there's also evidence that you might be able to speak to that relates to genetic changes that can occur among children who are exposed at a young age that make them more sensitive to nicotine effects if they initiate smoking. So I was just curious if you knew more detail about that.
That's interesting. So I don't know about genetic changes. I have seen epigenetic studies about children. So for those of us, just to make sure we're on the same page, you have some genes that you're born with, but I like to think of epigenetics kind of as, if you thought of a lamp as a light switch. If you had a lamp and the cord is broken, that's a genetic change. If you put a blanket over that lamp and the light went out, you still got the light going out, but you can take that blanket off. So that's an epigenetic change. And I have seen studies of children that have been grown up in homes that were exposed to tobacco, that they had epigenetic changes. And that was associated with, interestingly, genes that we thought were involved with metabolizing nicotine, but also reward centers, right? So more like neuropsychology, things like that. But that's a great question. And I think that it complicates things because I know we talked about this. Genes are not necessarily deterministic, right? We think about like risk and we think about how it relates to the lived environment and the built environment and lived experiences. So I think that epigenetic factors play into that. And so right now I'm not focused on epigenetic factors, but in the past I have. And I think that is something that's really been seen when we think about smoking over the life course, right? And biological changes over the life course with these type of exposures.
So I want to pivot a little bit, just a half pivot, over to this idea of treatment, because obviously these genetics and the epigenetic changes impact response to treatment. Dr. Dunn, I think you did a really nice job of kind of taking us into the work that you do when you're with people. And one of the things that I was struck by, your position is rather unique. I don't know of too many mental health professionals and clinical psychologists who are working in dental schools and so forth, and I think it's fantastic. Tell us a little bit about the challenges, though, of trying to work with the dental students and the residents who you can get them to buy in that helping patients to smoke is important and maybe is in their realm of responsibility. But given that many oral health providers only see patients a couple times a year, how challenging is it to move the needle in those relatively short visits?
Yeah, I mean, that's interesting. The last thing you said there is that, a dental provider has the opportunity to see someone once, if they're lucky, if the patient's lucky to have the insurance, twice a year, right?
Mm-hmm.
That's actually more than a lot of people see their primary care physician. So when I talk to the dental students, I say, you are a primary care provider, right? I mean, you have the opportunity to see patients. You have the opportunity to look into their mouth and smell their breath. And if they're a smoker, you might know, right? And you're doing that oral cancer screening. So you really do have the opportunity to have that conversation. And I can also pivot to alcohol, right? I think only about a third of patients know that there's a link between alcohol consumption and oral cancers and any cancers. So there's a lot of education that can be done. I think one of the biggest barriers that I've sort of experienced so far in having my conversations with students is they think that they're going to bother patients. They don't think patients want to hear about it. Now, my predecessors have done research that shows that patients are open to having their providers, their dental providers, even dental students, talk to them about smoking and smoking cessation. So they're open to it. 70+% are open to it. The other thing is it's not all or nothing, right? We think harm reduction. We think about what's the process. If my goal going into a conversation with someone who's smoking is I need to get them to agree to a quit date, I need to get them to agree to quit, that is, learned helplessness is going to kick in because you're not going to have a lot of success rates. If your goal is just to have a 3 to 5 minute conversation with them, that literally is moving them towards quitting at some point down the line. Research has shown that the continuance of those 3 to 5 minute conversations continue to move a patient further down that stages of change, right? And so it's those little wins. If you can open up a patient to have that conversation with you, they've had a successful interaction with you. They know the resources, they know who they can come to. You don't have to hit a home run. You just want to, get that hit or get a walk to throw out a sports metaphor.
Yeah, I'm thrilled also that you talked about dentists and oral health professionals functioning almost like primary care providers. Because a few years ago, one of our colleagues, Dr. Gina Trapicchio, was working with some of your dental residents and one of the faculty members there on something similar, which was can they have conversations with children and their parents about decreasing the use of sugar sweetened beverages, and through the lane of association with dental caries and so forth. And we kind of it was new to me at the time, but kind of once you thought about it, you realize, well, wait a minute, if you're seeing a dentist once or twice a year, that's as frequent as you're seeing your pediatrician perhaps or your primary care physician. And And if everybody, and if all of the providers are on a similar page, I won't say the same page, but a similar page in terms of health maintenance behaviors, then that means the amount of times that patient is hearing the reminder of think about what you're eating, think about what you're drinking, think about setting a quit date, it becomes that much more reinforcing over time. Brad, related to this, what's it been like working with pediatricians in this space and their willingness to join this fight, given everything else that they have to deal with?
Yeah, it's interesting because the very first trial that I conducted in this space with maternal smokers was proposed with the assumption that I'd be able to get referrals from pediatricians. And in the first year of the project, I was not getting any referrals from pediatricians, despite my efforts going into clinics, making partnerships, and things just weren't happening because of a lot of the challenges and barriers and time constraints in primary care. And I did a little side study to understand what some of those barriers were. And they had to do with the belief that the parent was not the patient. And so how can you, as a pediatrician, try to address parental health behaviors? The other part was, well, I can't prescribe to them, so I can't give them or prescribe NRT, nicotine replacement products. There were, the obvious barriers around the time commitments and time constraints, as well as beliefs that they didn't know enough about tobacco or what to say to parents to facilitate smoking behavior change. Now, that was like 15 years ago. We used that information in our subsequent trial, the multi-level trial with pediatricians. And at that point, which was about 7 years later, pediatricians were at least saying that they were aware of the best practice guidelines. They were saying that, well, I always ask about smoke and refer them, but as we got into it, that was inconsistent. But there was a willingness and an acceptability to being trained and understanding more about how to embed screening and advice and referral practices. So we were successful in it. And they, so they've evolved to a point where they're more comfortable addressing the issue with parents. And I think there's an opportunity in dentistry too, around secondhand smoke and the link between secondhand smoke and dental caries, which hasn't really been translated yet.
I'm glad to hear that pivot has taken place from that the parent is not the patient, because I reflect back even to, when I would take Ethan for his well child visits and the questions that when he was younger and I was still in the room, that actually were directed at me in terms of seat belts and firearm safety and those types of things. So yeah, I'm glad to hear that. And now I think about it, there was questions about smoking and was anybody in the home smoking. So I'm glad to hear that they're more willing than they used to be. I want to pivot a little bit to something that both Dr. Hahn and Dr. Mitchell referenced in passing, that it seems like that some individuals, and again, maybe it's those individuals from underserved groups, it's almost like a double whammy. Meaning, Dr. Mitchell, you talked about not only the smoking, but you talked about the radon exposure, and Dr. Hahn, you've talked about other exposures in neighborhoods and the environments around us. Can you both comment a little bit about the potency of that double whammy? And I mean, is that something that we all need to be worried about? That when factors collide, our risk factors go up? And just as a reminder to everybody, if you have questions or comments, do feel free to start chiming in as we get to our last 10 or 15 minutes or so. But Dr. Mitchell, Dr. Hahn, let me turn that over to you.
Yeah, I mean, I say this, especially from our environmental health field, I think we call that it's a double jeopardy. So it's like kind of not only for the surrounding environmental disparity, but also individual home disparities compared to, let's say, the affluent neighbors or individuals like us. It's like it is true that their exposure levels are much higher than us. And so it's a concerning, especially in the United States standpoint wide. But in just thinking about the global scale, I think there's still, even though their exposure levels are high in the United States, in the global scale, probably it's like kind of more lowering down. It's like on the middle ranges. But I'm not just kind of the less empathize about the importance of this one, because as a public health professional, we are always caring for those who are exposed to a relatively higher level than just the medium or 50% or majority of the population. We always want to protect people who are very vulnerable and also likely to be exposed to very high levels. Our ultimate goal is to everybody has a right to enjoy the clean environment and also the free from the contaminant or the social stressors. So that is kind of philosophy I'm in this field. So speaking of that, especially those underserved population, I think they are unfortunately having two major issues right now. The first one is a very high crowding in their own homes, especially because of those the minority and the low-income population, their population composition size is much larger than us. And then also their house size is relatively small. So because of the very crowded condition and their level of the environmental exposure is likely to be much higher than us. And also because of their living the standard, and also mostly their job is very requires a lot of work hours every day. It's like, let's say, maybe starting from 7 a.m. until like maybe 8 p.m. or 9 p.m., maybe having 2 jobs or 3 jobs. So because of that, they don't have time or resources to maintain their house sanitary or the cleaner than the normal people. I think that's the kind of one of the issues that we have to tackle with, especially from environmental health sciences standpoint. And then another thing is like the outdoor of the home is like kind of we working together with the community partners or policymakers that we especially for the like related to heat exposures or maybe some kind of the stationary pollution sources like maybe industrial sources or maybe some kind of the truck depot or something like that, working with the policymakers and then community organizations kind of help them to raise their voice and then raise the concern and deliver the message to the policymakers and then make the policy changes to remove those the kind of the local polluters as much as we can. But especially for this second part takes a lot of time because changing the law and the regulation, implementation of the regulation takes longer time than what we think. I mean, we cannot solve the problems like within a month or maybe even within a year. So I think that those type of providing those kind of background information and also the educating especially the community members to understand the process is also important.
Dr. Mitchell, what are your thoughts on this area?
So I want to echo some of the things that Dr. Hahn said that are really important. The first, thinking about policy. So I am an advisor to the Pennsylvania Department of Health, the Office of Health Equity, and I'm also a member of our state's Pennsylvania Cancer Coalition. And one of the things that we've done in Pennsylvania to think about exposures, we think about tobacco smoking. We've talked a lot about that today, but also the environmental exposure to radon. And, initially from a policies perspective and, all hands on deck, we say we're going to target smoking cessation and we're going to target residential radon. But what we now do from, a collective effort in the policy, our state cancer control plan has changed, is that anytime we talk about smoking, we're also talking about the residential radon. So we're taking into account that many people in the state are being exposed to both of these types of exposures. And so from a public health perspective, we have to address both of them simultaneously. We don't have to look at these separately. That's very important. Second, thinking about residential exposures and then thinking about occupational exposures and the sum of these. And so in particular, I study residential radon, and radon is odorless, colorless, tasteless. We don't typically think about it until someone tells you, we have the 4th highest in the country, and the fact that 40% of Pennsylvania homes have too high radon. But you may also go to a workplace. You may also pick a child up from a daycare. You may also go to a school, right? And so I think that thinking about these collective exposures are really important when we're assessing risk, but not just thinking about that these two are important for synergy for developing cancer, but thinking about how does that impact treatment, right? So we talked about treatment a little earlier. We really don't know the impact we know that smoking when it comes to cancer leads to poor outcomes. We know that when people continue to smoke, we often don't think about that group, right? It's like, well, you have cancer, why would you smoke? Well, if it was because of stress, you're definitely not less stressed with a diagnosis, right? But the important part is thinking about, are those same patients also exposed to this environmental, for example, like radon? And then what does that do to treatment outcomes? So we need to think about that from a risk perspective and prevention, but also from a treatment perspective. And definitely, I think we're doing really well from a policy perspective, thinking about risk, but I think we need to move the needle when we think about in a clinical space in the treatment.
Mm-hmm. So my last question for you, all of you, hearing from one another, learning a little bit about your work, where do you hear logical collaborations in your areas of interest? They're not binding, but if you had an opportunity based on what you've heard from each other today, where do you see your work intersecting and having some synergy?
Well, I guess I can start there. I definitely think with Eugene and Bradley, our mutual interest in smoking cessation and the most vulnerable of these populations, and thinking about motivation to quit and evidence-based clinical trials in this space. And I think with thank you, definitely environment exposures, thinking about synergistic exposures, and something that I'm also interested is nighttime, right? And with these exposures look like in vulnerable populations, and thinking about novel, culturally tailored CBPR interventions and what that would look like with environmental exposures.
Mm-hmm.
Yeah, I mean, from my end, I see a lot of opportunities, such as because the focus is like more cumulative exposures and the health impact. So for example, as Dr. Mitchell already mentioned, it's like residential home exposure, indoor air quality is my major interest. And also how to reduce the indoor air quality is utilizing, let's say, the air purifiers, because throughout the COVID, many residents are very interested in using high efficiency of the air purifier. And then also another question is like sustainability, and also they want to know what would be the effective indoor air quality, the air purifier or something like that. So I think this like utilizing my low cost sensor air quality monitors, and also cumulative exposures. Now, I mean, indoor air quality also includes radon exposure as well. So radon and the smoking. So it's like I see a lot of really huge opportunity working with all of you, and then also the behavior scientists or the community organizations and so on. So those are the kind of maybe just a little bit of a snippet that I see right now. I have other ideas coming up right now, but I will just preserve my time.
And Eugene and Brad, how about you?
Yeah, I mean, clearly between Doctors Mitchell and Dunn, there's obvious overlap and similar interests, parallel interests where we could cross-inform one another. So I certainly am eager to have follow-up conversations. And then with Dr. Hahn, Steve Lepore and I are interested in trying to improve, as I mentioned before, trying to improve the precision around which we're assessing changes in smoking behaviors in the home. And there are currently exist off-the-shelf air particulate monitors, but they don't do that great a job at differentiating between the different sources of PM 2.5 air particulates. So somebody somebody smokes in a home and you know, the air particulate levels go up. If somebody burns something on the stove, the air particulate levels go up. If somebody's smoking cannabis as opposed to tobacco, there's really no differentiation between what the source is. So we're interested in trying to figure out ways to improve that technology to differentiate that. In addition to some of the supportive accountability informed strategies of how we might link that type of air monitoring to you know, opportunity for in time or real time feedback from counselors for how they might be able to problem solve different difficulties with reducing smoking in the home. So I could see opportunities for some pilot work with Dr. Han to kind of get us moving in that direction.
Right. Yeah. So the Dr. Collins, I just want to chime in. So even though you utilizing humidifiers, the boiling water can also increase the PM 2.5 levels.
And Dr.
Yeah,
Dunn,
and
I'll give you the last word.
definitely. Yeah, I mean, I think all that's been said is all really great ideas, and I think, you know, David, I really appreciate you bringing us together as Dean of Research. This, I think, was a great exercise, and you know, to get us out of our individual silos. And you know, I think also I look forward to learning more about Dr. Collins' work on multimodal approaches. I think, you know, that when we work with patients, and so many of our interventions focus on this sort of one thing, but really we know that it's not a one size fits all. You know, we need a menu of options for people at different times and different people. So I think that's great. And then one thing we haven't mentioned is, you know, especially thinking about the pediatric and adolescent populations, is vaping and e-cigarettes, you know, as a gateway to ultimately, you know, the more cancer-causing tobacco products that are more traditional. You know, I take the subway to work often, and you know, I don't know if they're gonna be able to solve all the smoking on the subway, or if they're just gonna have a smoking car at some point. But I think there's a lot of research that could be done.
Yeah, I think that's actually a great forward-thinking point to end on. And you know, the purpose of this exercise was not to force collaborations between the four of you, but I'm glad to hear that there's some genuine enthusiasm, and I certainly would encourage you to reach out to one another as appropriate. But also, as I said at the very beginning, there's genuine enthusiasm um, from the senior leadership of all three of the colleges represented here, to bring people together to think creatively about this work. And so if there are things that I can do, or Marisol, or Erica and Glenn up at Fox Chase and Carolyn to move these things along, by all means, don't hesitate to reach out and tap us on the shoulder. But I do want to thank all four of you for you know, rising to the challenge of talking about your work without slides. And I think you did a really beautiful job of playing off of one another and building off of one another. I feel like I learned a lot. Now I feel like I also got to go and change my air filters in my home. But but I want to thank you guys for all of this. And for those of you still on the call, just as a reminder, next week is the college's Teaching Excellence Symposium, which I think is a great event for us to come together and learn from one another and our colleagues who you know, are excelling in the classroom and sharing those lessons with all of us, so we can borrow from them as well. But again, I want to thank our panelists for a great discussion, and everyone go and enjoy the beautiful weather outside. Take care, everyone.
Thank you very much. Have a
Okay,
nice
thank you
weekend.
very much.